Mood disorders. Module 1, Major Depressive Disorder, Assessment, Nursing Care, and Treatment Overview. Major depressive disorder is one of the most common and disabling psychiatric conditions worldwide. As nurses, we must understand not only the diagnostic criteria, but the safety priorities, risk factors, and biological mechanisms driving this illness. In this module, we will focus on assessment, suicide risk, pathophysiology, and nursing interventions, all through an NCLEX lens. Depression is the leading cause of disability in the United States and globally. It affects mood, cognition, behavior, sleep, appetite, and energy. Untreated depression increases risk for suicide, cardiovascular disease, substance misuse, and functional decline. This is not just sadness, it is a systemic disorder with serious consequences. Certain populations are at increased risk for major depressive disorder. Women, individuals with a first-degree relative with depression, survivors of trauma, LGBTQ youth, older adults, individuals with chronic medical illness. On NCLEX, always assess context. Risk factors guide clinical judgment. To diagnose major depressive disorder, symptoms must last at least 2 weeks and represent a change in functioning. Use the mnemonic SIGECAPS. S, sleep disturbance. I, interest decreased. G, guilt or worthlessness. E, energy decreased. C, concentration impaired. A, appetite changes. P, psychomotor agitation or retardation. S, suicidal ideation. At least 5 symptoms are required, and 1 must be depressed mood or loss of interest. On exams, always assess suicide risk when depression is present. Depression does not look the same in everyone. In children, irritability may replace sadness, and somatic complaints are common. In older adults, depression is underdiagnosed. It may present as fatigue, memory concerns, or withdrawal. Suicide rates are highest among elderly men. Clinical takeaway: never dismiss depressive symptoms as normal aging. Major depressive disorder frequently coexists with other psychiatric and medical conditions, with anxiety disorders being the most common comorbidity. Because symptoms overlap, such as sleep disturbance, poor concentration, fatigue, irritability, and somatic complaints, nurses must conduct a thorough assessment to determine whether anxiety is occurring alongside depression or driving the clinical picture. It is also essential to screen for substance use, chronic medical conditions, pain disorders, and thyroid dysfunction, all of which may worsen mood symptoms or complicate treatment. The presence of comorbid anxiety often increases functional impairment and suicide risk, making comprehensive assessment and integrated care planning a nursing priority. Major depressive disorder does not have a single cause. It develops from the interaction between biological vulnerability and environmental stressors. Understanding both domains is essential for accurate assessment and safe nursing care. Depression is associated with decreased availability of key neurotransmitters, including serotonin, norepinephrine, and dopamine. These chemicals regulate mood, sleep, appetite, motivation, and concentration. When neurotransmission is disrupted, patients experience the core symptoms of depression. Hormonal imbalances can contribute to depressive symptoms. Examples include postpartum hormonal shifts, perimenopause, menopause, thyroid dysfunction, and adrenal disorders. Before diagnosing primary depression, endocrine causes must be ruled out. Chronic stress activates the hypothalamic pituitary adrenal axis. Persistent elevation of cortisol can impair sleep, appetite, memory, and energy regulation. Over time, this dysregulation may contribute to structural brain changes and sustained depressive symptoms. Emerging research links depression to inflammatory processes and immune activation. Chronic medical conditions such as cardiovascular disease, diabetes, chronic pain, neurological disorders, and vitamin deficiencies may contribute to or mimic depression. A comprehensive medical assessment is essential. Individuals with a first-degree relative who has depression are at increased risk. Genetics increase susceptibility, but they do not guarantee illness. Environmental stress often activates this vulnerability. Environmental factors also play a significant role. Common contributors include trauma, grief and loss, relationship disruption, financial instability, chronic caregiving stress, and social isolation. These stressors may trigger a depressive episode, particularly in biologically vulnerable individuals. Depression is rarely purely chemical and rarely purely situational. It is typically the interaction between biological susceptibility, psychological patterns, and environmental stress. This is known as the diathesis stress model. Not everyone exposed to stress develops depression. Vulnerability matters. On NCLEX, assess both internal and external factors. As nurses, we must assess broadly, rule out medical contributors, evaluate psychosocial stressors, and ensure safety before making conclusions. When assessing depression, suicide risk is the priority. Ask directly, are you having thoughts of killing yourself? Assess thoughts, plan, means, intent, previous attempts, substance use, social support. Never assume that asking increases risk. It does not. Safety always comes first. Common nursing diagnoses in major depressive disorder include risk for suicide, hopelessness, ineffective coping, disturbed sleep pattern, imbalanced nutrition, social isolation, self-care deficit. The diagnosis determines the priority of care. Successful outcomes focus on safety and functional restoration. The patient will verbalize decreased suicidal thoughts, demonstrate improved sleep, maintain adequate nutrition, participate in at least one daily activity, express realistic self-appraisal, engage in treatment planning, use the SMART format to ensure outcomes are measurable and realistic. Use open-ended but simple questions. Avoid false reassurance or minimizing statements. Instead of, "You'll feel better soon," say, "I can see this feels very heavy for you." Presence matters more than advice. If suicide risk is present, implement suicide precautions, remove harmful objects, provide close observation, maintain a safe environment. Safety is always priority number one. Sleep and nutrition are not minor details in depression. They are foundational. As nurses, we promote sleep hygiene by gently limiting daytime naps, encouraging a consistent bedtime routine, and reducing stimulation before sleep so the brain can begin to reset. When appetite is low, we monitor weight and intake closely and suggest small, frequent meals rather than overwhelming portions. Depression drains energy and motivation, so our role is to simplify and structure. Offer simple choices, break tasks into small steps, establish structured daily routines, encourage behavioral activation, reinforce small accomplishments, avoid overwhelming the patient. When we help stabilize the body, we create the conditions for emotional recovery. Physiological balance supports psychological healing. Treatment for major depressive disorder is multimodal and often includes psychotherapy in addition to medication when indicated. As registered nurses, it is important to understand both the therapies available and our scope of practice. Supportive therapy is within the RN generalist role. This includes active listening, validation, encouragement, reinforcement of strengths, and helping patients stabilize emotionally during periods of distress. Supportive presence and therapeutic communication are powerful nursing interventions. Other evidence-based psychotherapies, such as cognitive behavioral therapy, CBT, dialectical behavior therapy, DBT, interpersonal therapy, IPT, and structured behavioral activation protocols, are typically delivered by advanced practice psychiatric nurses, psychologists, masters, prepared social workers, or licensed therapists who have specialized training in these modalities. CBT focuses on identifying and restructuring distorted thought patterns. DBT emphasizes emotional regulation and distress tolerance. Interpersonal therapy addresses relational stressors and role transitions. Behavioral activation promotes structured engagement in meaningful activity. While RNs may reinforce skills learned in therapy and support adherence to treatment plans, the formal delivery of these structured psychotherapies falls within advanced practice scope. Understanding these distinctions ensures safe, ethical, and collaborative care. In addition to psychotherapy, many patients benefit from pharmacologic and somatic treatments. Antidepressants, including SSRIs, SNRIs, TCAs, and MAOIs, are pharmacologic options. Antipsychotic medications may be used as adjunct therapy in patients with treatment-resistant depression. Brain stimulation therapies such as electroconvulsive therapy, or ECT, may be indicated for severe, treatment-resistant, or suicidal depression. For detailed coverage of antidepressant medications, side effects, serotonin syndrome, and brain-stimulating therapies nursing care, please refer to the separate PsychoPharm and non-pharmacologic interventions video series, Unit 2 and Unit 7. This allows us to focus here on assessment and nursing management while ensuring you have comprehensive medication knowledge. An important clinical pearl. When antidepressants are initiated, energy may improve before mood does. This creates a temporary window where suicide risk may increase. Monitor closely during early treatment phases. If you see a depressed client, ask yourself, is this patient safe? What is their suicide risk? Are basic needs being met? Are there medical causes contributing? What level of care is required? Depression management is not passive. It is active assessment and intervention. In this module, we covered assessment, suicide risk, biological foundations, nursing diagnoses, expected outcomes, and interventions. Major depressive disorder is not simply sadness. It is a condition requiring active nursing management. Understanding depression is foundational to psychiatric nursing practice. In the next module, we will explore persistent depressive disorder,